So this is on psychedelic-assisted therapy, and I would encourage everyone listening to really not think of psychedelics as drug treatments. At present, all of the larger clinical trials that have been conducted with psychedelics have been conducted in the form of psychedelic-assisted therapy, and sometimes this is called psychedelics with psychological support. But regardless, there is a fairly stereotyped therapeutic process in which the psychedelic is administered. And this is not only to mitigate the potential harms associated with people getting scared and having challenging or negative experiences from psychedelics, but also, as I mentioned, to really help catalyze therapeutic change. That if there's this neuroplastic state, neuroplasticity in and of itself in a neutral environment is usually not going to mean anything. One has to make a change and take advantage of the neuroplastic state to have that change stick. And so I'll explain a little bit about how the therapy works. But first, I want to talk about psychological safety. So as I mentioned, for most participants and for most of these psychedelics, medical safety is mostly a given. They are physiologically quite safe. It's really psychological safety that needs to be considered, which is kind of unique in terms of research. When I'm submitting something to the IRB, I really need to be thinking about how to protect patients from the psychological effects of psychedelics, honestly, more than the medical effects. There's not many agents that's a consideration, or at least the primary consideration, right? So you've probably heard the term bad trips. We don't use the term bad trip anymore. One, just because it obviously has some baggage associated with it. And number two, because we say challenging experiences rather than bad trips, because in most cases, when people have challenging experiences, this is not the entire duration of the psychedelic session, but it can be intense when it happens. So what are challenging experiences? So these can occur in a variety of modalities. They can take the form of just simple anxiety to panic or dysphoria, all the way up to frank paranoia and delusions. The variety of modalities they can occur in, people can have sensory feelings and illusions. There can be somatic hyper-awareness of body processes, distressing personal thoughts about the self, and even metaphysical thoughts, fearful thoughts about the world, society, evil forces, cosmic forces, stuff like that. Psychologically, when people start fighting with this or try to avoid the psychological experience that they're having, this tends to make it worse. Secondly, it's generally believed that in most cases, when a challenging experience occurs, it's kind of the way we think about emotional difficulties in more classic psychotherapy, particularly psychodynamic therapy. This is grist for the mill, and it's an opportunity for the participant to really dive into whatever it is, try to trust the process, be open to what's coming up, and to feel their way through the experience. And this happens with the support of the therapist team, right? So these studies generally have been conducted with not one, but with two therapists present. And one of the main roles of the therapist is to assist the participant in the studies when these things come up, to help them to kind of trust in the process, to go deeper, and to see if they can kind of come out the other side with some new insights into whatever was causing this distress. Now, there will be pharmacological agents as backup. They're rarely used, but they have been used in some scenarios. So usually you're going to have a benzo on hand just in case. And if not, there's going to be an atypical antipsychotic available for extreme situations. There is some screening that needs to be done. So not everybody is thought, at least at present, based on what we know, to be a good candidate for psychedelic-assisted therapy. So people with a personal history of a psychotic episode, personal history of a true manic episode are thought to potentially be at risk of adverse effects from psychedelics, of having their condition worsen. Most American studies have gone a little bit further and also screened out anyone who has a family history, who's a primary family member with either a psychotic disorder or type 1 bipolar disorder. So when we think about generalizability of these studies, important to note that these are very, very carefully screened people in all of the studies that you've seen up to this date. It may not be, at least at this point, very generalizable results, given how careful the screening has been. What is HPPD? HPPD stands for hallucinogen persisting perceptual disorder. And this refers to something that's been seen going back to the 1950s, where people have some kind of persistent perceptual re-experiencing of something that first occurred during psychedelics. Now, there's certainly a lot of people out there And I've seen some of them who have this. But what's curious is that this has never been seen in any modern clinical trial. So it's unclear if this is a truly organic or brain-related impact of psychedelics, or rather this may be more of a traumatic response, or maybe both, that might be much more likely to occur in recreational use, which often is unsupported the way that people have been supported in these studies. Or perhaps that this may simply be due to the fact that people who develop HPPD are people who are at risk based on factors that have been, up to this point, screened out of any of our modern clinical trials. So how does psychedelic-assisted psychotherapy work? Psychedelic-assisted psychotherapy has three key parts. So there's the psychedelic session in the middle, and these are preceded by preparation sessions, which establish rapport with the therapist dyad. They collect information about the participant, and they help to psychologically prepare the participant to really trust and be open to the psychedelic session. You don't want people coming into the psychedelic session expecting that this is going to be easy, expecting that there's going to be this amazing euphoric experience with no dark corners. This is really not, somebody's thinking like that, they're really not a good candidate for this. And so working with them in the preparation to be able to be a little bit more neutral and open to whatever may come up is really the main purpose of preparation. After the psychedelic session, there are a number of what are called integration sessions. And this is really just aimed at letting the participant speak to what their experience was, be supported in processing or meaning making of what came up for them during their psychedelic session. And it's thought that the integration sessions are really likely key to helping people solidify whatever these changes may be that they're going to get longer term, such as reductions in depression or anxiety. But really, the opportunity for talking is going to come during the integration sessions. And it's thought that the more the person can spend inside with their own thoughts and their own feelings of whatever is coming up, the more the opportunity for therapeutic change there is. So like I mentioned, the therapist dyad is present, but patients are encouraged to have an internal experience. So the psychedelic session itself usually doesn't have a lot of talking. So you'll see in the picture there's some headphones. So people are offered eye shades and headphones and really instructed to go inside and to just try to sort of calmly be open to whatever is coming up. They need to talk, the therapists are there, but really the opportunity for talking is going to come during the integration sessions. And it's thought that the more the person can spend inside with their own thoughts and their own feelings of whatever is coming up, the more the opportunity for therapeutic change there is. Set and setting is a term that many are probably familiar with. This goes back to the 1960s. We know that the set, which is the mindset the patient goes into the psychedelic experience with, matters, and we know that the external environment also matters. So set and setting refers to an ideal both internal and external environment. So these are not treatments that can be done in very sterile hospital-type settings. And so most of these academic hospital centers that have done this research have outfitted their rooms and tried to humanize them as much as possible and make them a little bit more similar to what one might find in a private practice office or even one's living room. Now, having told you this, you might be already thinking that this model probably is going to cost a lot of money. And indeed, at this point, I think things are certainly looking that way. So even for a protocol that might have only one psychedelic session, let's say it has 2 preparation sessions that might last 90 minutes, psychedelic session lasts 8 hours, 2 integration sessions lasting 2 hours each. Each one of these sessions has 2 psychotherapists present. In a lot of these studies, one of them is a psychiatrist. So this is a very resource-intensive paradigm, particularly given the fact that up to now, at least one and sometimes both of the therapists have been people with doctoral level degrees. So this is going to present a very large challenge for scalability and for cost. I think there's a lot of room for innovation with the therapy itself. And as I've alluded to throughout this talk up to this point, there's also some competing medical philosophies that I think will also be a challenge, indeed that are a challenge now to kind of explaining how these treatments work. In modern medicine, we tend to be very prescriptive. We tend to mostly tell the patient what to do, even if it's just, take sertraline every single day. The idea of psychedelic-assisted therapy is really non-directive. It's simply to be present for the patient and to encourage the patient to have their own process and to determine in a supportive environment, but really on their own, what is important for them. And so in this way, psychedelic-assisted therapy is more akin to practice-based modalities such as mindfulness than as a treatment per se. And so we're seeing some clashes as these things that are now being researched as treatments are coming to the level of FDA approval, and how we're actually going to work with them clinically, when I think most of us are really not well-versed in thinking of therapeutic change more as something that's the result of a practice or a process. Lastly, as I've mentioned, the idea of the mystical experience, right? This is maybe not a religious term, but it hints at it. It's certainly not a purely secular implication when one speaks of the mystical experience. And if it turns out that the mystical experience truly is crucial for therapeutic change in psychedelics, I think it's both a challenge given our hypersecular orientation of modern medicine, but also potentially a real opportunity to expand the sphere of scope of practice of what practitioners are doing and what dimensions of human functioning we're really looking at in terms of both treatments as well as ideas of wellness in our patients. So the key points here are that psychedelics are unique and that the primary concern tends to revolve around psychological safety as opposed to medical safety. We know that challenging experiences can occur during a psychedelic session, and we emphasize the need for psychological support or therapy prior to, during, and after the medicine sessions. Psychedelics are not standalone drug treatments. That could change, but that is not the way to think about them now. They are offered in a paradigm of psychedelic-assisted therapy, which includes the preparation for psychedelic experience, supportive care during the session, and integration therapy following sessions to reinforce and solidify therapeutic insights. Psychedelic-assisted therapy is paradigmatically unique in psychiatry, and as such faces significant challenges ranging from a philosophy that is fairly anathema to biomedical paradigms to substantial upfront costs and related issues of access. These challenges have yet to be solved.